So I'm Dr. Shilpa Bhartia. I'm a hematologist. I've done my MRCP and FRC path from UK, and I'm back in India 12 years. So I'm going to try and share some knowledge about hematology. So that's going to help you in your exams. Today, I have decided to just start off basic with approach in anemia. And anemia itself is a very, very big topic, and there is no way I can, get all the information to you in 2 hours. So we're going to try and do as much as I can. And it's very important to know this when you're studying hematology, because, this is the basis of what we are going to study about. So, this is your hematopoietic stem cell, which we know divides into the 3 lineages. You've got your red cell lineage, which is the erythroid series. You've got your myeloid series, starting with the promyelocyte, and you have your megakaryocytic series. The whole differentiation pathway is very important because every pathology is related to some problems in any part of the differential pathways, starting from the stem cell disorders such as leukemias and MDS or aplastic anemia to red cell disorders. And you have the white cell disorders such as your in the differentiation pathways, your chronic myeloid leukemia, your chronic lymphocytic leukemia, and of course, your megakaryocytic problems, which is your ITP or other bleeding disorders, functional platelet deficiencies. So I think this chart is something you have to know throughout your hematology practice, is what is a normal differentiation pathway of the stem cells in the hematopoietic stem cells in the bone marrow. So when we start off, first of all, we have to be very clear with the normal ranges. Anemia is defined as reduction in hemoglobin. In males, it's less than 13.5, and in females, it's less than 11.5. There is slight variation nationally and internationally. You need to be aware of that. The results of anemia is decreased oxygen carrying capacity, which causes shortness of breath, weakness, lethargy, palpitations, headache. And if left untreated, causing cardiac failure, angina, causing intermittent claudication, confusion, and it can cause visual disturbances due to retinal hemorrhage. Each of these points is very important because they can give you any of these features in your MCQ, and they're really trying to point out that you need to be aware. I've seen several patients who presented with the retinal hemorrhage having hemoglobin as low as 2 or 3 grams, and they're having visual disturbances. So each of this is very important. So when you're approaching an anemia case, it's looking at diagnosis. It is due to the underlying causes. So when you're looking at the cause, you have to think of 4 different main sectors. Either your cells or red cells are not being produced. There is failure of production, which is usually something infiltrating the bone marrow, or it is aplastic anemia, or there is a hemoglobinopathy where there is a defective gene and it does not let you produce your normal red blood cells. How about failure of absorption? This is when you have your nutritional anemias, that you have a celiac disease, you've got pernicious anemia. These are the malabsorptive syndrome. Or if you don't eat itself, there's nothing left to be absorbed. Then you have your hemolytic anemia, which is due to excessive either destruction or demand. So your hemolytic anemias, infections like malaria, which present with severe anemia, and when there is an increased demand, which is a physiological maternal anemia. And sometimes you have everything, the bone marrow is producing it, there is no absorption problem, there is no hematinic deficiency, but there is this failure of utilization. That means there is enough iron in the body, but the bone marrow is not able to utilize this iron, and that is called anemia of chronic disease, and happens in a multiple range of inflammatory disorders, autoimmune disorders, rheumatoid arthritis, SLE, or simply people who have got multiple comorbidities, and you've excluded your other cause. Only then you're going to call this as anemia of chronic disease. This is one way of looking at anemia, causes of anemia. The other way which we do practically and which will be more useful for you both in clinical practice and in multiple choice questions is breaking it as per the size of the red blood cell. So if you know, the normal MCV varies a little bit again from lab to lab, but somewhere around 80 to 95 is the normal MCV. Anything below 80 is called microcytic. Anything above 95, 96 is called macrocytic, and in between that range is normocytic. So you have to divide your causes of anemia into microcytic, normocytic, or macrocytic. It's only when you look at this parameter in detail, you will be able to order the correct set of investigations, because they will very specifically ask you what is your next investigation or what is the diagnostic test to confirm your suspected diagnosis. So when you are looking at a picture with a microcytic anemia, the few things should just flash into your brain. The first one undoubtedly will remain iron deficiency. Hemoglobinopathies like thalassemia, alpha and beta thalassemia will have microcytic anemia. Hereditary spherocytosis may have a very mild microcytic anemia because they have a reticulocytosis, it gets balanced. Sideroblastic anemia presents with a microcytic anemia. And the other thing is lead poisoning. Lead poisoning is a very favorite MRCP question to try and confuse you with iron deficiency. So always keep that in the back of your head. Then before going to normocytic, I'll go to macrocytic. Again, there are defined causes where you will find a macrocytic anemia. The first one is in our country is B12 and folate deficiency. Abroad is, you get alcoholism as a major cause of macrocytosis, but pathologically you've got myelodysplastic syndrome. Those with having a hemolytic anemia, the macrocytes, the cells increase in size because you're seeing the reticulocytes come into the blood, and reticulocytes are larger than the normal red blood cells. Hypothyroidism is a cause of macrocytosis without anemia. And there are many drugs that cause macrocytosis, especially those who are having hydroxyurea for myeloproliferative disorders. They have a macrocytosis, and that is one way of checking compliance, whether they are taking the drug or not. So if you have these wide causes in your brain, you will be able to investigate them properly. Then comes your normocytic anemia. That means the MCV lies in the normal range. And the causes are slightly different, but very important to see is people who have got mixed hematinic deficiency. That means they've got severe iron deficiency also and B12 deficiency. So if they don't eat anything, they're going to have a dual deficiency. So what happens? You have some cells that are microcytic and some cells that are macrocytic. So when you have and if you look at the overall MCV, it's an average, right? So it balances out and you got a normal MCV. But what you have to see is the red cell distribution, with which I will talk to you about a complete hemogram. The other very common cause of normocytic normochronic anemia with normal hematinics, they will often try to see whether the patient has got an underlying myeloma. So look at the clues very carefully. A normocytic normochromic anemia with high ESR, maybe mild renal impairment, they are usually trying to hint you towards myeloma. MDS, yes, majority are macrocytic, but they may be normocytic as well. Anemia of chronic disease is usually normocytic. This is another very common question. Those who have got leukemia, the anemia is due to bone marrow failure, right? So the sizes are generally not different. And acute blood loss. There has been no time for the red cell size to change. So if there's an acute blood loss, you will see that the anemia is normocytic, normochromic. So this slide is very, very important for you. So whenever we are trying to know what microcytic, normocytic, or whatever, you first need to very thoroughly keep in head is your normal ranges. Yeah. So your hemoglobin, as I said, male 14 to 16, women 12 to 15. This varies a bit from country to country. And this is normally good as your UK standards. Read this very carefully. The red cell count. Yeah. And you'll know why in some of the MCQs we'll discuss maybe in this one or in the future sessions is if you have a microcytic, I want somebody to, answer this question. If you're having a hemoglobin of 10, an MCV of 69, and a red cell count of 5.5, what is going to be your next investigation? Somebody needs to answer quick, otherwise we'll be stuck on the slide. I can't see anyone, so somebody needs to answer. If it's not going to be interactive, it's not going to help you. Even if you're wrong, just answer.
Aspirants, please do verbally interaction.
Bone marrow aspiration, bone marrow biopsy.
So I'm telling you, it's a hemoglobin of 10, a MCV of 69, and a red cell count of 5.5. What is the differential that is going on in your head? I remember
serum
I've said
ferritin.
yeah.
Serum ferritin.
Okay, if I tell you the serum ferritin is normal, what is your next thing that hits your head? This will be an MCQ question. Take it from me. I have told you the red cell count is 5.5.
Maybe ring sideroblast. We will look for ring sideroblast.
What about thalassemia carrier? Have you not seen in your clinical practice reports of patient having microcytic, hypochromic, very borderline low hemoglobin and a high red cell count? This is characteristic of a beta thalassemia carrier, and your next investigation of choice is going to be a hemoglobin electrophoresis to look for a high HbA2 to confirm a beta thalassemia carrier. This is one of the most common mistakes, not only in exams, but also in clinical practice. You look at an MCV of 69, you assume it is iron deficiency and you start iron treatment. You have to be very important that the red blood cell count will be low in patients with iron deficiency anemia, whereas in thalassemia carriers, your red cell count is going to be high. So every time you review a hemogram report, look at each and every value, because that's where your diagnosis is going to lie. Similarly, you have to look at the reticulocyte count. You have to ask for this test. If the reticulocyte count is below 0.5, you know it's a bone marrow infiltrative production issues. Whereas if the reticulocyte count is greater than 2, 3, 4, 5, you know it is a hemolytic problem. There is no problem in the bone marrow producing the cells, and you will not do a bone marrow test in these people. So when they ask you what your next test is going to be, based on the hemogram report, you're going to have to exclude certain pathologies, and these values are going to help you to decide which way. And you have to always keep going back to my slide of micro, macro, and normocytic, because everything is based on these three slides. If you know these three concepts and these three slides, you will hardly ever go wrong in investigating an anemia. Okay, so I'm just going to start this case. It's a 45, read every line, okay? It's a 45-year-old non-vegetarian hypothyroid lady who presented with symptomatic anemia and jaundice. There is no history of excessive blood loss, and her hemoglobin was 6.2. Her white cell count and platelets are normal, and her bilirubin was 3.5, majority of which was unconjugated. She had an ultrasound which had showed it is a mild splenomegaly, right? So what do you think is going on? Anemia with the unconjugated bilirubinemia?
So there is hemolysis going on somewhere.
Yeah, so we think it is a hemolytic anemia. So what are we going to do next? Tell me what investigations you will want to do next. You have to know what your hemolytic screen is. Some of it I have given you, some of it you have to tell me. What information you want from me?
Peripheral smear, DCT.
Okay, yes. But before that, you want to ask me something?
The reticulocyte count
is high.
Okay. So that means it's not a bone marrow infiltration. That means the bone marrow is producing plenty of reticulocytes.
Yeah. What information do you want from me? This slide. Come on. What are the red cell indices? Don't you want to know? Are you dealing with a microcytic anemia or a macrocytic anemia? Okay, what do you expect the MCV now that you know it's a hemolytic anemia?
We expect the MCV will be low on the lower side.
Okay, go back to this slide. Hemolysis.
Oh, okay. Okay, macrocytic. Okay.
Yes.
In fact, the lady has hypothyroidism also.
Yes, and she's a non-vegetarian. So why have I stressed on non-vegetarian?
For B12 deficiency, so that we don't go for B12 deficiency. Because it is strictly in red.
Correct. So you want an MCV, very good. You said a peripheral blood smear is important. You have a hemolytic screen. You have to do your LDH. Know this. This is important. In a hemolytic screen, you need your CBC, you need your smear, you need your reticulocyte count. LDH. What happens to LDH in a hemolytic patient?
It will be elevated.
Elevated, and you need the direct Coombs test. So at this point, you know, non-veg, this, that, you don't know what your other reports are. You are going to think, is it a autoimmune hemolytic anemia or a hereditary spherocytosis? I don't know. She's a 45-year-old presenting with anemia, and we have asked for these tests. So, of course, you know, when a patient comes in your chamber, you have to know other medical history. So she's had history of recurrent mouth ulcers, skin rash, some vaginitis, and her hemoglobin was also 8 grams 1 year ago. So you start thinking, does she have any autoimmune blood disorder? So this is what her blood smear showed. She had an MCV of 116. Her blood smear showed gross anisocytosis, polychromasia. These purplish cells, if they show you, are polychromasia. She had occasional spherocytes, like these one, very thick stained cell spherocytes, and some hyper-segmented neutrophils. Her LDH was grossly elevated. Her retics didn't show very much of, you know, it wasn't very high. And her DCT was also positive. So it can be, so again, once I see an MCV is there, I got hyper-segmented neutrophils, what level would you want to know? Hyper-segmented neutrophils is classical of?
B12 and vitamin B12 deficiency.
Yes, vitamin B12 deficiency. So most people would think, oh, she's 6.2, she's symptomatic, let me transfuse blood or start steroids. But if you look, she had a vitamin B12 level of 67, which is very low. The range is a bit wide, anywhere from 180 to 200, depending on the lab, to 900. Her extended Coombs test was positive, which was a cold antibody. Her autoimmune panel was negative. So we had to start treatment of her autoimmune hemolytic anemia, as well as give her B12 injections. Her endoscopy was done as an anemia workup because she had mouth ulcers, and that was normal. So the diagnosis is,
Ma'am, can you please explain the concept of Coombs test once? I mean, I'm not clear with the concept of Coombs test.
Yeah, so hemolytic anemia is when you can develop autoantibodies against your red cell surface antigens. So when these autoantibodies go and attack your red cells, they are going to cause hemolysis. The way of testing this hemolytic process in the lab is called a Coombs test, where they add an anti-IgG antibody in a serum of patient serum with antibodies against the red cells. And I have to do a diagrammatic presentation of that. If you want, there are specific questions. I will note it down and make specific slides and share it with the academy so that you can follow that.
Yes,
but you are looking for this agglutination of red cells with the antibody, and it is now done through gel cards, where you will put the patient serum in a pre-antibody, in a gel which is already pre-coated with the anti-human antibody, IgG antibody. So as soon as you put the serum, and if it has got antibodies, the cells will agglutinate and the blood will remain on the top layer, saying it is a autoimmune hemolytic anemia. Why do we need extended Coombs test? Okay, now this is again a little bit deep into hematology. We know autoimmune hemolytic anemia is of two types. Yeah, we've heard about the warm autoimmune hemolytic and the cold hemolytic. So if it is complement mediated or antibody mediated, so cold hemolytic anemia is complement mediated. When you have the C3d positive, then it is called a cold autoimmune hemolytic anemia. So it is important. These anemias may or may not respond very well to steroids, but you may need to add rituximab, whereas the warm antibodies respond very well to steroids. That is why it is always important to do an extended Coombs test to know whether it is a warm type or a cold type. In this case, it was a cold type of hemolytic anemia.